Hello guys, welcome to Pajon Imaging Hub. In today radiographers and other professionals education series, we look at swimmer's view, common mistake that can ruin the image after all the struggle to produce this image. We'll look at some of these tiny mistakes that can mess up the image that you've produced. Welcome back. So what is swimmer's view and why is it important? And what are these positioning tips and common mistakes we should be knowledgeable? Swimmer's views is used to see a C7 to C7T1 junction. That is the cervical thoracic junction. Why is this view has to evolve? In trauma cases that involve the spine, that is the cervical and thoracic region, this joint, the C7T1 junction, is particularly susceptible to injury. So there is high risk of that joint having problem during trauma. And in normal lateral and cervical, that is normal lateral cervical and thoracic X-ray, the shoulder, especially patient with dense muscular shoulder, obscure this joint. So in normal laterals, you don't see them clearly. I would like to state that CT is the preferred imaging modality to visualize this joint. But in a situation where there is no CT or the cost implication cannot be brought, they'll have to know how to produce this image in a better way. How is the positioning done? The patient may be done a right or spine. If it, but the main thing is that the mid sagittal plane, the patient mid sagittal plane should be parallel to the image receptor. This is the image receptor. Then the patient mid sagittal plane, the line that divides this patient into left and right at the mid section, that is the patient mid sagittal plane, should be parallel to each other. But for patient on spinal precautions, a patient that you are suspecting a spinal cord injury, you are not meant to tilt this patient to achieve this. Instead, you tilt the tube and the cassette to align parallel to the mid-sagittal plane of the patient. The second tip in the position is that the arm nearest the receptor should be the one that will be raised over the head. The arm, the other side, closer to this receptor, is the one you raise. While the second one, the shoulder will be depressed, so this hand will be put down and the shoulder is depressed as much as possible. The essence is to ensure vertical separation between the two shoulders. While this one is put up, raised over the head, this one is depressed down. So that will ensure separation between the shoulder there and the one here to be able to visualize the C7 and T1. So the centering point will center just above the shoulder or 2.5 cm above the jugular notch. And the collimation, how do we collimate? Of course, we want to include the C7 and T1 as the main focus, but we have to include a structure that will serve as a landmark that can help for easy identification of the C7 and T1. And what is preferred is to include C2. C2 helps for easy identification because it has large spinous process, so it can easily be identified, and then from there you can count down to C7 and be able to identify the C7 and T1. So if you don't include this structure, you may find that you produce an image that is difficult to even know the place to look. So in collimating, you have to include the C2 and T3. Then this is a bulky part of the patient. He has to use grid If you cannot, if the patient cannot be aligned to use the pocket, there are some situations where the table can be moved closer to the pocket. If such a case is not possible, or the patient cannot be erect, then a grid has to be used to obtain the image so as to give a better image quality. Then exposure is done on arrested respiration to reduce movement, thereby ensuring reduction of motion and sharpness. That is help to get a better image quality. Factor you use, though depending on the machine you use, most of the digital image work on automatic exposure control. So you don't need to select factors. They have already been included as part of in configuration of the machine. But if you're still in a place where you have to manually select factors, or where the AEC is not working adequately, then you can use 120 to 150 ms and 80 to between 80 to 90 kVp depending on the size of your patient. So let's look at the image and see how these tiny things we do can help us to get a better image. You see, this is the image. This, looking at this structure, we can identify the C2. You see, it is big, so it makes it easy. We can count down from there to locate the C7 T1. Yeah, it is of no use doing this kind of X-ray, and the radiologist, whoever reports the image, cannot identify the C7 and T1. So count down. This is C2, C3, C4, C5, C6. So this is C7. See, the spinous process is tilting downward. Remember, the C7 resembles the spinous process, while the rest resemble each other. So this junction here is the T1, is the C7 T1 junction. This place is the cervicothoracic junction. So we can actually visualize the joint space. Yeah. Thank you. Like, share, and subscribe. Bye for now.